Hey guys, I'm going to be presenting today on Down syndrome. This is also called trisomy 21. It's when the person has a third copy of the 21st chromosome instead of two copies. This happens during meiosis. The 21st chromosome is the smallest chromosome. It has 48 million base pairs. I know that sounds very large, but it's actually only 1.9% of our DNA. There's also it's an autosomal aneuploidy that happens between the chromosomes. Remember back from earlier this year, we talked about meiosis, and it's a division that has a first phase and a second phase that creates daughter cells. So in meiosis, most trisomy 21 usually occurs in the first phase, that's 73% of the time, and in the second phase, usually 25% of the time. There's also a very rare form of trisomy 21 that is a mosaic trisomy, instead of the most common, which is the aneuploidy. When we talk about risk factors, usually you hear, advanced maternal age. If you're over 40, it's going to increase your risk. There's a lot of different numbers out there for the increase in risk, depending on how much, or how many years over the age of 40 you are. The older you are, the more likely it is to happen. And this is usually because the abnormality isn't normally like an inherited thing. It happens like as a random event during the formation of reproductive cells in the parent. And the abnormality usually occurs in the egg cells. Occasionally it occurs in the sperm cells, but most of the time it's in the egg cells. And that's why being an advanced maternal age is a risk factor. Also, being younger than 20 years of age increases the risk as well. And it about matches advanced maternal age, and we don't often hear about, being younger than 20 years of age as an increased risk factor. Being Hispanic ethnicity, that also increases your chance of having a child with Down syndrome or trisomy 21. There has been studies about the methylene tetrahydrofolate reductase gene, also the MTHFR is what people normally call it. And it's not something that's proven yet. It just, at this point, studies show that there has been an association that's found with that gene and Down syndrome. It's important for us as midwives to know what kind of testing we can do in pregnancy. And although we call it testing in pregnancy, really, I think screening before testing is better, because you're not adding all the risks, the neonatal risks that come with it. So in the first trimester, you can do a blood test and an ultrasound. The blood test usually is the integrated that you also would do in the second trimester. And then there's the NIP testing that tests the pregnant person's blood and gets the fetal, fragments of DNA and tests that way. This is a screening, not diagnostic testing. If you choose to do the integrated part, you often are going to do the second integrated part later on. These tests for the NIPT, you want to be around 10 weeks of pregnancy. And that's kind of the earliest screening that you're going to be able to do during pregnancy. If any of that screening comes back saying, there's a chance of this trisomy 21, then that's a time that may indicate diagnostic testing, conversations Ultimately, the client is the person that should decide whether or not they want to do diagnostic testing. There's amniocentesis, and that should be performed from 14 to 18 weeks gestation. There's chorionic villus sampling, and that's done earlier in the first trimester. So realistically, that one's not done too often because the NIPT testing or screening is usually not done until 10 weeks. And then we also have umbilical cord sampling, and that's done in the second trimester around 18 to 22 weeks. The ultrasound that I didn't mention in the first trimester screening, it can be done then, but normally ultrasounds by the ultrasonographer are not usually done until 20 weeks. So that one's not a technique that's used as much anymore now that we have the NIPT or the NIPS screening. When we're discussing this with the client, we should always, talk about the risks that are associated specifically with diagnostic testing, such as fetal death or injury, preterm labor, and infection. In our prenatal exams, things that we might find in the gestational parent would be, when we're doing measurements, we would notice that, the baby might be small for gestational age and have fetal growth restriction. There may be excess of amniotic fluid, which is polyhydramnios, placenta insufficiency, that could be found in the ultrasounds, as well as in Doppler abnormalities, and like different congenital heart defects are something that's found in newborns, and so prenatally we might hear that on a Doppler with different heart defects that could be present. About 50% of all babies born with Down syndrome are actually also born with a congenital heart defect, so it's very common. Hearing loss, up to 75% may be affected, and between 50 to 75% of babies are actually going to have obstructive sleep apnea, and 60% are going to have diseases like cataracts. Also, there's brush-filled spots, and some of the other things. Hip dislocation is actually not quite common, but it is something to look out for that we do in the newborn exam. You're also going to possibly see, but not all the time, there is a wide range of different findings in a newborn, and you may only find some of these things, and a lot of the time, not all these things are present. But you may see a flattened skull, an enlarged tongue, syndactyly of the second and third toe, which is like what most people call webbed toes. You can have clinodactyly of the fifth finger, that means a bent finger. And some other possible symptoms might be hypogonadism or cardiac malformations, duodenal atresia, which is like a congenital bowel obstruction. So intestinal blockage is something that you might see. Later in life, there's, things like thyroid disease, anemia, iron deficiency, leukemia. You're also might, see that excess skin on the nape of the neck that could have been found in the ultrasound. Babies might have low birth weight. There may be like a space between the second and first toes. It's called a sandaled gap. Small, low set ears, flattened nose, obstructive sleep apnea. The joints between the skull bones might have space, short hand with wide fingers, and decreased muscle tone. What's important to know is that when we're giving prenatal care after a baby's born, you're going to want to do karyotyping of the blood on the baby and also the parents. There's difficulties in postpartum care, such as feeding problems, respiratory problems, weight gain, vomiting, blood disorders, epilepsy, And so it's important to connect people that we're counseling into support groups, a genetic counselor or therapist or occupational therapists as well. It's important to have conversations with our clients about what their fears are, what to expect when the baby's born, and help them and aid them into ways that they can be more prepared, and also supporting people that choose to not continue with the pregnancy. And here are my references. Thanks so much for listening. Hope you guys have a great day.